Morning everybody. Today we are going to talk on acute diarrheal disease in children. Now this topic we will be learning in these under these sections. One is definitions, what is the etiology, what is the pathogenesis, mechanisms, clinical manifestations and assessment of dehydration, principles of management. In that mainly we are going to cover oral rehydration therapy, nutritional management, zinc supplementation, drug therapy, and in prevention we are going to cover the vaccines which are helpful in preventing viral diarrhea. Okay. Now why this disease is important? What is the magnitude of the problem? Diarrhea is the second leading cause of death in children under 5 years of age. Okay. The first cause is respiratory infections, that is lower respiratory tract infections like pneumonias. They are the primarily leading cause of death in children under 5 years of age. Globally 1.7 billion children are affected every year and the under 5 mortality is very high, especially in children below 2 years of age. And in India every year we have 1.3 million deaths due to diarrhea in children. Okay, so the magnitude of the problem is that large. It is the second leading cause and it is a major contributor to the under 5 mortality, especially in children below 2 years of age in a developing nation like ours. So here in low income countries they have done studies and in which they have found multiple causes of death in children. So you primarily have pneumonia, diarrhea, and others are infections like malaria, HIV, AIDS, neonatal sepsis, birth asphyxia and prematurity. But if you see almost 40% are contributed by these only. Now you should be clear about certain terminologies in diarrhea. What is diarrhea? Diarrhea is the passage of unusually loose or watery stools at least 3 times in 24 hours period. Okay. So remember there is a change in consistency as well as there is increase in frequency. Okay. So there is acute and there is persistent. So what is acute? Sudden onset of excessively loose stools of more than 10 ml per kg per day in infants and more than 200 grams per 24 hours in older children. So in infants it will be 10 ml per kg per day, more than that, or 200 grams per 24 hours in older children. So what is persistent diarrhea? Any episode of diarrhea that begins acutely and lasts for more than 14 days. So that is persistent diarrhea. What is dysentery? That is blood in stools is known as dysentery. Okay. What is the risk factors? Now the child is suffering from acute diarrhea. There are certain risk factors which predispose the child to suffer from this problem. Okay. The first thing is breastfeeding. Failure to breastfeed exclusively till 6 months of age. Sometimes what happens? Some introduction of the formula or early weaning, something they do and they cut down the breast milk, or the mother is not well to feed the child at least exclusively. What is exclusive? No other forms of feed should be given, even including water, except mother's own milk. So failure to breastfeed exclusively till 6 months of age. Failure to continue to breastfeed until at least 1 year of age. That means even though weaning has started, she has to supplement along with the weaning, continue breastfeeding also. Using infant feeding bottles or formula feeds. Now the problem with formula feeds or any top feeds is that one is dilution. Sometimes because of poor affordability they will dilute the feed excessively, or what they will try to do is in people who are affordable they try to make the formula more dense. Okay, more hyperosmolar, that is putting more powder, because of which the child may have osmotic diarrhea, or the feed is not prepared properly in a hygienic way, or they use feeding bottles and through the teat the child may get diarrhea. Along with that the child may get respiratory infections, otitis media also. So 3-4 problems can come because of bottle feeding in children. Then delayed weaning. Many times what they do is they try to prolong the weaning. So once 6 months is reached, the output or production of the mother's milk decreases, and you have to supplement, because of a growing child the requirement will be more, so you have to supplement it with weaning foods. So if there is a delay in weaning, again the child becomes malnourished, and that malnourishment and diarrhea is also a vicious cycle. Then malnutrition, in a developing country like ours, malnutrition is common, and malnutrition predisposes to low immunity, and that can cause diarrhea. Illnesses like measles, pneumonia, inadequate vaccination. Now rotavirus vaccine is covered under the government schedule. Okay, so even that people are not taking. Immunodeficiencies like IgA deficiency, environmental factors like improper sanitation, lack of hand hygiene, low socioeconomic status, and contamination of food and water. Like we said, or like we discussed, diarrhea and malnutrition are a vicious cycle. So what happens in diarrhea is that there are loss of nutrients or increased catabolism. Okay, then once the nutrients are lost and there is increased catabolism, there is a decreased absorption, poor feeding, decreased appetite, and that disposes to malnutrition again. Okay, so he is not taking orally well, is not able to meet the basic caloric demand, then he is predisposed to malnutrition. Once the child becomes malnourished, then again he is going to have low immunity, low mucosal integrity of the gut mucosa, and again this will predispose again to infections of any form. It could be a respiratory infection or a GI infection like diarrhea. So diarrhea and malnutrition are a vicious cycle. So as to understand the concept of rehydration therapy, you should know the total body water in the compartment. Now this is a little different from an adult. Okay, so the intracellular water, total body water in a child is 40%, and the extracellular, which composed of interstitial as well as plasma. So interstitial is 15% and plasma is 5%. Okay, so your diarrheal losses are the extracellular compartment. So 25% it will be contributing. Now where are the plasma anions, cations and intracellular cations? So predominantly in the plasma, the cation is the sodium and chloride. Okay, and in intracellular compartment, usually potassium is a predominant cation. Okay, so your losses when you are going to see in diarrhea are all going to be all the three, but mostly it will be sodium in the initial phases. So what is the etiology? Now you have various etiologies, but in children the rotaviral infection or the rotavirus diarrhea is predominantly the major contributor to this infection. So more than 20 viruses, bacteria and parasites have been associated with acute diarrheal disease in children, and rotavirus commonly is the severe cause of severe diarrhea. Okay, in developing countries. So other viral agents include the enteric viruses like adenovirus, astrovirus, human calicivirus, and bacteria like E. coli in that enterotoxigenic, enteropathogenic, enterohemorrhagic, enteroinfectious E. coli, Shigella species, Vibrio cholerae, Salmonella species, Campylobacter jejuni, and Clostridium difficile. Now Clostridium difficile more common in hospital acquired infections. Okay, then parasites also contribute, like they contribute more to a dysentery picture, but in some cases they can cause diarrhea also, like Entamoeba histolytica, Giardia lamblia, Cryptosporidium, Trichuris trichura, and Strongyloids. So remember, it is usually rotavirus, and these are commonly other causes. Okay, now what happens in viral diarrheas? Now the virus replicates in the villus epithelium and it causes patchy epithelial cell destruction. Okay, so once there is a cell destruction of the villus epithelium and villus shortening, that decreases the absorptive surface. So there is a patchy epithelial cell destruction as well as shortening of the villus. So when these two happen, the absorptive surface goes down. Okay, and normally the other mature cells like the absorptive villus cells are replaced, which are helpful in absorption, they are replaced by immature secretory crypt-like cells. So the mature cells are replaced by the immature secretory crypt-like cells, which cause secretory diarrhea. Okay, so loss of disaccharidase enzyme like lactose malabsorption. Okay, then rotavirus protein, that is the NSP4, it also acts like an enterotoxin. It stimulates the calcium ions which stimulate chloride secretion by the crypt cells. Okay, so you are going to see lot of purging in viral diarrheas. Okay, so we understood no that there is a decrease in absorptive surface by there is a destruction of the cells, epithelial cells of the villus shortening. Now, the mature cells are replaced by immature secretory cells, loss of enzymes which help in absorption, and a viral protein which acts like an enterotoxin and causes calcium to be released, which stimulates chloride secretion by the crypt cells. So this is predominantly the inflammatory action of the non-inflammatory action of the viral diarrheas. In bacterial diarrheas, there is a mucosal invasion. So the mucosa gets invaded directly. There is a destruction. So the common area which is involved in children is colon and distal ileum. Okay. So the invasion can cause micro abscesses, superficial ulcers, toxin production, and then it can also cause histological damage resulting in altered cell morphology, then decreased sodium and chloride absorption. So we know that in Shigella and enteroinvasive E. coli, these mechanisms are seen. So assessment of a child with diarrhea. Now when a child comes to you with diarrhea, a mother brings a child to your OP. So you are going to ask first the history and then you are going to examine the child. So in the history, what you are going to ask is, are the stools watery? Is there any blood in the stool? What is the frequency? That is duration here. From when did it start? That is the duration. What is the frequency? How many times in a day? Is it associated with any vomiting? How is the urine output in the child? Is it associated with any fever or pain abdomen? What are the nature of fluids administered? Whether they have given home available fluids or they have given any kind of ORS. Okay. How was the feeding of the child before the illness and during the illness? And have they used any drugs for the treatment of this infection? Have they vaccinated the child adequately? And was the child suffering from any diseases like measles or a respiratory illness prior to this diarrheal episode? Okay. So all this in history you are going to ask. You are going to ask about the stool. You are going to ask about the vomiting, urine output, and other features of other infections like fever, then any measles, any respiratory illness, how was the feeding, then vaccination. All this you are going to cover in the history. Then physical examination. Once you look at the child, you are going to look at the signs of dehydration. Along with that, you are going to look for the nutritional status of the child and any associated infections suggestive of like pneumonias and otitis media. So, how is the baby or the child going to present to you? He will present you with a sunken fontanelle, reduced level of consciousness or lethargy, dry mucous membranes, reduced skin turgor, tachypnea, tachycardia, sunken and tearless eyes, reduced capillary refill time, hypotension, peripheral vasoconstriction, sudden weight loss, oliguria. So more like a hypotensive, hypovolemic shock he might present in the severe diarrhea. So when the child is brought, during your examination, you are going to look at the child and you are going to observe certain things. Once you have finished observing, then you are going to feel something, decide and treat. So you are going to look at the child, then depending on that you are going to decide under what plan he should be given, is he fitting, and under what severity he is fitting, and what treatment should be given. Now look at the condition. How is he? How is the child? Whether he is well and alert, whether he is restless and irritable, or whether he's lethargic, unconscious and floppy. Okay, then how are his eyes, whether they are normal, sunken and tearless, if sunken and tearless. Okay, so absent of tears is present in moderate and severe variety. Okay, then mouth and the tongue. So once you are finished with your eyes, you are going to see mouth and tongue, like how it is it moist, is it dry, or is it like parchment, like that means very dry. Then thirsty, whether he is drinking normally, whether he's drinking, he's thirsty and he drinks eagerly, or the child is not able to drink at all, like he's too lethargic, he is unresponsive, he is not able to drink. Okay, so once you have looked at his general condition, then you are going to feel his whether how is the hydration of the child. So you are going to look at the skin pitch, whether it is going back quickly, is it going back slowly, or it goes back very slowly, like it is hardly, it remains in the same position. Okay, then based on your looking and your feeling, that means looking at the child as well as examining personally, you are going to decide whether there are no signs of dehydration, whether if more than two or more signs are there, so these are your signs, then some dehydration, and two or more signs of severe dehydration, then you are going to classify them accordingly as no dehydration, some dehydration and severe dehydration. And then you are going to treat plan A if the child is having no dehydration, plan B if the child is having some dehydration, and plan C then if he is having severe dehydration. So in plan, when your in child is having some or severe dehydration, you are going to weigh the child before you start the treatment. Okay, assessment of fluid loss and degree of dehydration. So if he is not having much of dehydration, he has just come to you with some symptoms and category A, that means no dehydration, possibility of assessment of fluid loss is less than 50 ml per kg. And in some dehydration, it will be around 50 to 100, and severe dehydration, it will be more than 100 ml per kg. So once you have assessed, you are going to manage. Now, what are the principles of management? The principles only does not mean hydration and maintaining hydration. It also means that you have to give adequate feeding to the child, supplement the child with oral zinc, and if there are any danger signs, to immediately recognize and treat, as well as treatment of complications. Okay, so first you are going to go for plan A, no dehydration. So first thing is, any deficit is there, you have to correct that. You have to also ensure daily maintenance fluid and correction of ongoing losses. So three things you have to do. One is deficit you have to correct. Second is ensure that there is a maintenance, daily maintenance. And third is ongoing losses. Otherwise the child is going to land up into the same problem. So plan A. So in plan A, what we saw, that there is no dehydration. So he can be treated at home. But when you are going to treat at home, you are going to tell the mother certain signs which you are going to explain. Okay, whether the child is having continuous diarrhea beyond 3 days, how will keep looking at the stool volume as well as the frequency, if it is increasing, if there is any repeated vomiting, is there increasing thirst, is the child becoming irritable, lethargic, is he having any refusal to feed, is it accompanied by fever or blood in stools. If any of these are present, then she has to immediately follow up with you, though she is receiving treatment at home. Okay, so amount of ORS to be given after each loose stool is, after every stool in a child who is less than 2 years of age, is about 50 to 100 ml. 2 to 10 years it is about 100 to 200 ml. This is after every stool. And more than 10 years it is ad lib, means the child is now big enough, he will keep accepting as and when his requirement increases. Okay, so minimum he should require receive is 500 ml per day in a less than 2-year-old child. 2 to 10 years 1000 ml per day, and more than 10 years is 2000 ml per day. Now plan B. Plan B should always be treated in the hospital. That is, a child who is becoming irritable, who is becoming who is having excessive thirst, who is not able to he's having decreased urine output and not able to feed properly. So you have to treat this child in the hospital. 75 ml per kg of ORS, because he needs supervised treatment, because he may land into plan C or severe dehydration. So 75 ml per kg of ORS to be given in the first 4 hours. If he is not taking orally, the child can be given through the nasogastric tube. If after 4 hours also the child still has some dehydration, then again 75 ml per kg over 4 hours may be given. Okay. Now ORS may be or orally giving may be difficult if the child is having very high stool purge rate, is having persistent vomiting, is having paralytic ileus, or like there is some problem with the preparation of the ORS. But usually intravenous fluids you have to give in all these three conditions, above three conditions. When the signs of dehydration disappear, then used to and the child is taking orally, you should administer ORS equal to the diarrheal losses. Okay. Then breastfeeding semi-solid foods can be given in the maintenance phase, that is once the deficit replacement has occurred. So plan C, but you should not stop feeding. Okay. So there is a misnomer that if you stop feeding, then all the secretions will come down and the gut will be rested. All that is a misnomer. You should not do that. Plan C also to be treated in the hospital, especially in a tertiary care unit. So ideal fluid is normal saline or RL. Now why you are going to use a normal saline or RL? So it is isotonic. So you have to use it somewhat, it should be near the plasma osmolarity. Okay. So age, if it is less than 12 months and more than 12 months, 30 ml per kg, 70 ml per kg, 30 ml per kg within 1 hour in a child who is less than 12 months. In a child who is older, that is more than 12 months, 30 ml per kg should be pushed within 30 minutes, and 70 ml per kg in a child who is less than 12 months over 5 hours, and in a child who is more than 12 months it is 2.5 hours. So remember half of that. Okay. So smaller the child, you are going to take more time, because you cannot overload the child. So with 1 hour and 5 hours and 30 minutes and 2.5 hours. Okay. If severe dehydration is persistent, you continue the IV fluids, don't stop. Hydration improved but some dehydration is present, shift to plan B. And from plan B, if the child is recovering well, shift to plan A. Reassess the child every 15 to 30 minutes for vitals and hydration status. So this ideally of 5 hours and 2.5 hours has to be completed. After that, you assess how is he and all. Some dehydration, plan B. Then no dehydration, shift to plan A. And if it's still having losses and is not able to take orally, continue IV fluids. So story of the oral rehydration therapy. It has been a boon. It is a boon. Especially they noticed it especially during the cholera epidemic of East India in 1970s in the eastern part. So it has been over a period of time has been improvised and then now it is made low osmolar ORS. Okay. Now what is the advantages? Correction of water and electrolyte deficit is possible orally, so you don't need a IV line. Okay, you can give it through the nasogastric tube also. It reduces mortality, cheap, easy, and it is a scientific formula. Okay, so in diarrhea, the absorption of sodium, potassium, chloride as well as bicarbonate is always normal unless some pathology exists. So glucose coupled with sodium absorption promotes water absorption across the intestinal mucosa along with the glucose sodium transporter. Okay. So maximal absorption occurs when sodium to glucose molar ratio is 1:1. Potassium absorption occurs by passive diffusion including water also. So keep rehydrating solution at a lower osmolarity as compared to the blood will cause greater absorption of fluid across the concentration gradients and electrolytes by solvent drag, that we all know. So here we are seeing this is the lumen, gut lumen, this is the intestinal epithelial cell, and this is the blood. Now you want all this to go into the blood. So if the sodium and glucose transporter is there through which the sodium and glucose will be transported from the lumen into the intestinal epithelial cell. Water is by passive diffusion. Then glucose through the GLUT2 will enter into the blood. Sodium potassium ATPase pump will regulate the influx of sodium and efflux of the potassium into the intracellular cell, in the intestinal epithelial cell. Then here is the water. Okay, some potassium regulation also occurs across the potassium channel. So, but this is the main one. Okay, and if the molar ratio is 1:1, there is maximum absorption, and the the osmolarity of the ORS should be slightly lesser than that of the blood, so that there is a maximal absorption by solvent drag. So what is the composition? Now the contents will be potassium chloride, glucose, sodium chloride, trisodium citrate dihydrate. So here, though this is providing energy, these are providing electrolytes. Here, this increases the shelf life of your trisodium citrate dihydrate, increases the shelf life of your ORS. So you want the total osmolarity to be 245, whereas sodium is 75 millimoles per liter, chloride is 65, glucose is 75 again, potassium is 20, and citrate is 10. So total becomes 245. So as you know how it is prepared within in 1 liter, and it can be stored for 24 hours. Now advantages is it is low cost, it eliminates the need for intravenous placement. Then treatment can be done at home and safe and very few side effects. Now limitations. It is the limitations of oral rehydration therapy use is difficult when the mental status is altered, like in aspiration or is having severe dehydration. If in a child with less than 6 months, it is very difficult to go for ORS and then treat, because the child will not drink, he will not have the and he can't drink more. Okay, so age of the child is small, he is having altered mental status, he is having some complications like paralytic ileus, abdominal distension, or the child has directly presented to you in severe dehydration. Is there any, if there is a high stool output, that is there is a very high purging in a child, like more than 5 ml per kg body weight, more than 5 ml per kg of body weight, or if there is severe or persisting vomiting, that is more than 3 episodes per hour. So either more than 3 episodes per hour, or if the stool rate is more, severe dehydration, complications are there, smaller the child and lower the mental status, all these are going to limit your use of ORT in the child. So along with your fluids as well as your ORS, you are going to do the nutritional management also of the child, as it worsens the nutritional status. So one is the decrease in food intake could be due to anorexia, maternal food withholding like we discussed previously, deficiency of macronutrients and some micronutrients, and complications like infection, CCF, nutrient deficiencies. So promote early feeding, which causes gut epithelial recovery, prevent malnutrition, continue breastfeeding even during dehydration, and this will help in causing weight gain and prevents persistent diarrhea. Energy dense staple foods like fats, oil, sugar, give in small quantities. Okay, don't give at the same time in large quantities. Again, that will cause osmotic diarrhea. So give in small quantities and frequently. Preferably try to avoid coarse fruits if he is purging very frequently, and the myth that routine lactose free feeds in all children is not required. Okay, in all children, if there is a secondary lactose intolerance or lactose intolerance, then you may withhold. Okay, in a bacterial diarrhea and all, if there is not much of secondary lactose intolerance, you may continue to give normal feeds. In non-breastfeed infants, undiluted milk usually they say should not be used, but you can use it by adding some cereal mixtures or rice mixtures, which will make it more energy dense. So like we said, nutrient dense food, and continue it till the child reaches the pre-illness weight, and ideally till the child reaches the normal nutritional status. Now zinc supplementation, role of zinc in acute diarrhea. So it is available as sulfate, acetate, gluconate. The primary action of zinc is it restores mucosal barrier, the mucosal barrier integrity of the enterocytes. That is, the enterocytes mucosal barrier, it restores the integrity of that mucosal barrier. Then it promotes brush border enzyme activity, promotes the production of antibodies and circulating lymphocytes against intestinal pathogens. So it has multiple role. Okay, so even in especially in diarrheal diseases, this has been a savior. Okay, savior. So which forms is it available, what does it do to the enterocytes, what does it do to the brush border enzyme activity, and it also promotes the production of antibody circulating lymphocytes against various intestinal pathogens. So the dose of elemental zinc, you have to see elemental zinc because it is available in various salts. So 20 milligrams of zinc per day above 6 months of age for 14 days, and below 6 months it is 10 milligram per day for 14 days. So drug therapy, when are you, most of it is viral and self-limiting. Drug therapy you may have to use in certain conditions. Systemic antibiotics in malnourished infants, like in severe acute malnutrition, you are going to the child is predisposed to many infections, like he can land with sepsis and shock, so you are going to give systemic antibiotics. Then in premature infants, well-nourished infants, if the child is presented with some complications like abdominal distension, poor suck, lethargy, fever, hypothermia, fast breathing, lethargy, inactivity, or if there is a history suggestive of any kind of cholera, dysentery, amoebiasis, or giardiasis. So in that you are going to give drug therapy. Then anti-secretory agents and probiotics. So now we covered the fluid, we have covered antibiotics, we have covered supportive management like ORS, so zinc, then probiotics and anti-secretory agents like racecadotril, which inhibit antidiarrheal effects by inhibiting intestinal enkephalinase. Okay, so it decreases the secretion by inhibiting intestinal enkephalinase. Okay, then probiotics, they are very have a beneficial health effect on health and human and they colonize the bowel also. They are used as an adjunct therapy, they are not used the primary therapy but as an adjunct or a supportive therapy in acute diarrhea, and strains are Lactobacillus rhamnosus, L. plantarum, and Saccharomyces boulardii. Then complications. So what are the complications you are likely to encounter if the child is suffering from acute diarrheal illness? One is dehydration. The dehydration could be an isonatremic, hyponatremic, or a hypernatremic. So here the plasma sodium level is 140 milliequivalents per liter, where the water and sodium losses are in proportion. Excess of sodium can cause hyponatremic, where isonatremic and the hyponatremic dehydration will cause the loss of skin turgor due to the shrinkage of extracellular water, causing impairing of skin elasticity. Whereas in hypernatremic dehydration, net movement of the water occurs from the intracellular to the extracellular fluid because of increased osmolarity, and the skin turgor will appear as doughy or leathery. Okay, and then that can cause complications like seizures, it can cause cerebral edema, seizures. Then it may present as a shock due to hypovolemia. Complications, one is we said was fluid loss causing dehydrations. Then electrolyte, then shock like hypovolemia, which can manifest as weak, ready pulse, low blood pressure, and cold extremities. Acute renal failure, which is pre-renal, mainly because of hypovolemia, decrease in hydrostatic pressure of the renal glomeruli, decreased filtration of the urine. Then there can be metabolic derangements, renal shutdown, like oliguria, which can be predisposed to anuria, metabolic acidosis due to the loss of bicarbonate in the stool causing metabolic acidosis. Then potassium depletion due to large fecal losses, signs of the potassium depletion which occurs cause signs of muscular weakness like hypotonia and paralytic ileus. So once you have treated the child, now you don't want the child to come back again. So how are you going to do is prevention. So adequate nutrition first is adequate. As a pediatrician or as a doctor, you are going to improve the nutrition status of the child. Then proper sanitization, you are going to educate the mother. Then vaccination. Now the rotavirus vaccine we are going to talk about is a live attenuated vaccine which is given orally, and the strain types are RV1 and RV5. The schedule is slightly different for RV1 and RV5. RV1 is 2 doses, RV5 is 3 doses at 6 to 14 weeks apart. Okay, between 6 to 14 weeks we have to give 3 doses when you are having the RV5. You have to give 2 doses when you are having RV1. Okay, and the interval between 2 doses will be 4 weeks like any other vaccine. Okay, so maximum age at which you can wait to give this, supposing they have forgotten to take the vaccine and come to you, you have to ask what is the age of the child. If it is less than 15 weeks, you may give the start the first dose. Okay, and uh, not later than 8 months you should give the final dose. That means between 15 weeks to 8 months you have to finish all the doses of a child who has presented to you late. Okay, 15 weeks will be if you have started the first dose. Within 8 months of age, you have to, of age of that child, okay, you have to finish the final dose. You're not going to wait 8 months after giving the this 8 months of the child. Okay, so do not start your vaccination series if he has already crossed 15 weeks of age. Okay, so what temperature you will store the vaccine is 6 to 8 degrees centigrade. The problem is earlier there were some side effects noticed with this rotavirus vaccination. That was now it's very rare, and the side effect is intussusception. But as we say, the benefits always weigh the complication or the side effects in case of a rotavirus vaccine. So diarrhea management in IMNCI. So IMNCI has also given some guidelines which are somewhat similar. And first is primarily you are going to assess the dehydration. Then you are going to classify and manage, treat diarrhea accordingly. If there is any dysentery, then you are going to manage that, and diet you are going to counsel. So this is what you are going to do. Does the young infant have diarrhea? Yes. If he has, then how long? Is there any blood in the stool? Then look at the infant. General condition, whether he is lethargic or unconscious, restless and irritable, sunken eyes. Pinch the skin of the abdomen, whether it goes back very slowly or taking longer than 2 seconds. Okay, then you classify for dehydration. Now, he has to have at least 2 or more than the following signs. Okay, then you are classifying it as severe dehydration. Now, if he is having only severe dehydration, you are going to give the first dose of intramuscular antibiotic and you are going to start the treatment. If he is having low birth weight and some other another severe classification, like is he having some otitis media or respiratory infection, respiratory distress, urgently refer to a higher center with mother giving sips of ORS on the way, continuing breastfeeding and keeping the baby warm. So if he is not able to, like we said, if he does not fit into this, then start treatment as per plan C in your own hospital. Now he is not having features of severe dehydration, but he has 2 or more features of some dehydration. Then similar way, in some dehydration also you have to see if the child is having low weight and severe disease fitting into any severe classification. Then you are going to first give ampicillin and gentamicin and immediately refer the child. Like I said, giving frequent sips of water, frequent sips of ORS on the way, continuing breastfeeding and keeping the baby warm. If he does not, then give fluids according to plan B, and once he is recovered from plan B, then you can discharge the baby and tell the mother when to return immediately. If he is not fitting into any signs of some or severe dehydration where not much of monitoring is required, then you may send the baby home, but you have to explain the warning signs to the mother like we said, and follow up immediately when any of these warning signs develop. Or if the child is doing well, she can follow up in 5 days. And if he's not, if he's improving but the problem is still persisting also, she can follow up. Okay, then if it is more than 14 days and it is severe, like we discussed, no association with another severe classification, then you have to start the refer the child. Then you have to give antibiotics, treat the low blood sugar, keep the baby warm, and then refer to a higher center. And if there is stool, if there is blood in the stool and the features of severe dysentery, you have to continue the treatment and administer the primary doses of the antibiotic and stabilize the child before your referral. Okay, so my some no, some and severe dehydration we have covered. Okay, so when you are going to read the diarrhea, about diarrhea, you are going to you are going to read upon the what are the risk factors for a child to who presents with diarrhea. Then you are going to ask how's the history, what points you are going to ask in the history. Then examination, depending on the examination, plan A, plan B, plan C. Treatment of the fluids according accordingly. Then oral rehydration therapy, you may have a short note also on that. Then supportive measures like administration of zinc therapy in a child who has presented with acute diarrheal disease, rotavirus vaccination, which is a very important vaccine and now included in the national immunization schedule, and along with that the nutrition which you are going to take care, and the complications to and the treatment of the complications. So in this way you are going to read, and you may be given a scenario in your as a question for 10 marks also, like a child has presented in shock, and then he is a child who is having severe acute malnutrition, and then he has weak pulse, he has thready pulse, cold clammy extremities. So how will you proceed? Then you have to directly, and he's a 8-month-old child, so then you are going to talk about primarily the management of the acute diarrheal illness, plan C. Along with that you are going to also talk about SAM also, and in that case, okay. So accordingly you have to read this topic, okay. Thank you.